Well, good afternoon, everybody. According to my computer, the time is 4 o'clock, which means that we can get started with our next installment of webinars coming to you from the Royal College of Surgeons of Edinburgh. A number of you are still loading yourselves up, so just a little bit of brief introduction whilst everybody else joins on. And then I'd like to introduce our speaker, Mr. David O'Regan, to you as well. It's great thanks, of course, to the college for hosting this, for putting in the time and the effort during this pandemic where most people have been furloughed and are working from home, for putting this together and making this happen. It's a massive thanks to Mike Silver, the director of the RSA network, and to all of the other speakers for coming together and to deliver you at this time what we hope is useful teaching and in some respects training of the things that you will encounter later on in your career. You will have the opportunity to ask questions. What I have noticed is when there's 400 of you, you ask questions as if there's nobody else in the room. I'd like you just to try and be respectful to our speaker when you ask questions and do it as though you were in the lecture theatre, please. In a lecture theatre, when I say any questions, no hands go up. What I've seen on the webinars is within moments of the speaker starting, there are 12 questions. So could you let Mr. O'Regan at least start before you start coming up with your questions? I will do my best to field them and to answer the ones. Anything that's off topic, I shall respectfully move on. And anything that is relevant, I will try and answer. If not, Mr. O'Regan will answer towards the end. Okay, so there's also the opportunity to like questions. So if somebody else asks one and you're happy with it, then like it and we'll see what we can do about getting that to the top of the list. Next Thursday, so in 2 days' time at 4 o'clock, please tune in for the next installment, which is the management of lower GI bleeding, brought to you by Mr. Boyce, and a flyer will come up at the end of this for that later on. Now, very briefly about Mr. O'Regan, a wonderful colleague, a highly respected and incredibly experienced cardiothoracic surgeon from Yorkshire. He is also the director of the Faculty of Surgical Trainers. So what Mr. O'Regan doesn't know and can't tell you is really not worth knowing. If you look carefully at his screen, you see the letters S and then his head and his another S. That doesn't stand for SOS, but that's what you probably do think when you see trauma. But this is an advert for the Black Belt of Surgical Skills, which is an online teaching and training, which is also live tomorrow night. And Mr. O'Regan will give you some details about that if you wish to join in with that as well. But he has a wealth of experience. And so I'm going to hand over to him now to lead us through blunt trauma to the chest. And at the end, hopefully there's a chance for us to answer some questions. Thank you, David. Over to you.
Well, Barney, thank you very, very much for that kind introduction. I wouldn't say I'm an enormous expert, but I've been practicing cardiac surgery for 20 years as a consultant. I'm director of the Faculty of Surgical Trainers, and I'm sitting in my home studio for the Black Belt Academy of Surgical Skills to enable you to practice your surgical skills at home. As I was thinking of this subject, I remembered my time as a registrar at St. Mary's Hospital when we had the call to A&E for a major incident with the Paddington rail crash. Now, some of you might be too young to remember that, but as I went down to A&E, I thought to myself, trains, heavy weights, people being thrown about. So I had in my mind a lot of blunt trauma to limbs and to the chest, and I was rehearsing in my mind what I was going to do. What surprised me, what came through the door, was not blunt trauma, but severe burns. And the first person I saw in Resus Bay 1 at St. Mary's Hospital had severe burns from the head to the waist. So first message is expect the unexpected. Now, you will understand from your anatomy that the rib cage actually protects all your vital organs. When you think about it, in the abdominal organs, your liver, your spleen, your kidneys are all tucked up underneath and behind the 12th rib because of the dome shape of the diaphragm. Then your heart, your lungs are within the rib cage, and the great vessels and the esophagus is at the back of the mediastinum. And the thing about the rib cage is it's very springy. So at the moment of impact, there could be an incredible amount of distortion of the rib cage, and it all goes boing and springs back. You might not see it on the outside, but you'll certainly be there on the inside. So what is blunt trauma? Forceful compression of the chest. Because it's springy, it goes like that and springs out. So anything from a crush or blast or blunt weapon. Blunt abuse of the chest in children may be an indication of child abuse. But of course, the elderly with their osteoporotic bones, a simple fall forward or backward or to the side from standing can cause a significant injury. But the most common injury of blunt trauma we will see in this country is from a vehicle colliding with a steering wheel, and either that stopping the forward motion or side motion or a seatbelt. And this is important. It's important to understand the mechanism of injury. So the history from the ambulance crew or the fire crew about the direction, the velocity, the fall, the height, the force is all going to give you clues on what to look for and what to be aware of. And that is essential. Now, there are stories of trauma people arriving at scenes and doing clamshell thoracotomies with penknives in order to save lives. That is not what this webinar is about. And I would suggest to you that thoracotomies to deal with blunt trauma should only be done by advanced or immediate care trained trauma staff. And that would come in major trauma centers or in the military, and is not for the faint-hearted, and it should usually be done by somebody trained how to open a chest. Because I've been down to A&E on a number of occasions when it seems to be a machoism to open the chest to stop the bleeding, and in fact there's more bleeding from the thoracotomy than from the wound itself, because it's been poorly opened. So please do not do that or be tempted. And it would not surprise you, therefore, that the very basics of trauma do lie in that A, B, C, D, E we know of trauma. The airway is important. First of all, contusion of the chest may cause bleeding in the lungs and bleeding in the airway, and that needs to be sucked out. But many people traveling might be smoking a cigarette, or eating a travel sweet or something, chewing some gum. That too might go in the airway. But as you attend to the airway, remember that any force to the chest will also have an effect on the neck, and the cervical spine is important. Now, B for breathing is where your clinical skills at your stage as a medical student come in as very important. Look at the chest, look for symmetry, look for paradoxical movement. Feel the expansion and asymmetrical expansion. Look for a flail when you breathe in, the chest going in paradoxically. Feel and look for emphysema. It feels like bubble wrap as you feel around the chest. But there's a very important clinical skill that I would recommend that you practice now, and that is percussion. And I did a study with the registrar on percussion. It's poorly done. And percussion and tactile vocal phonemic tests are really your clinical ultrasound. And if you're in the lecture theatre with me now, I'll get you to all stand up, and I hope you can hear that. Barney, give me a thumbs up. That is percussion. That's resonant. I know my lung is full and expanding. But if it's stony dull, that is probably fluid, and in a trauma case, blood. And if it's more resonant than that, it is probably a collapsed lung and a pneumothorax, both of which require chest drains. So in my previous talk, I talked about chest drains, and that'll be on the webinar series. But chest drains save lives. And in many trauma centers, the first thing they do with breathing, when people come in with a crush injury, chest drains go in automatically before they even go to the CT scan. Because if you're compromised in your breathing, hypoxia is not going to help your situation at all. The other thing is fractures of ribs, and because your heart and major blood vessels in the chest, there could be a profound loss of blood. Muffled heart sounds might indicate a tamponade, tachycardia. And a simple rule of thumb for you to determine somebody's blood pressure is, I call the rule of 20s, from your ankle to your wrist, to brachial artery, to femoral artery, to carotid, falling down in 20s. If you can't feel it at one point, but feel it at another point, it gives you an indication of the blood pressure. But of course, with all trauma, this is not usually just the chest, and you need to expose the patient and examine them all over. And a simple bit of bruising might indicate more severe injury. Don't forget spinal injury, brain injury, so therefore pupils, asymmetry, spine, deformity, loss of function of a limb, all indicate spinal problem. And that needs to be borne in mind as you're treating the thoracic injury. What are the hints that you would have at the degree of symmetry? Well, one, more than 2 ribs is significant. But even if you can see 2 rib fractures, there are usually more of those. And you usually see them at the back, along there, and you won't be visible on a chest x-ray. Multiple rib fractures would cause a flail, so paradoxical movement of the chest. So if you think that your tidal volume is only a few hundred mils of air, that paradoxical movement could obviate your breathing. The other important thing to remember is that from the spine to the flat first ribs to the manubrium, that is a rigid circle, and together with the clavicles on either side, makes a rigid structure for your thoracic inlet. And any break of bilateral clavicles or anywhere along the first ribs usually indicate that the force of injury has been profound. And if it's that profound, the sudden increase in venous pressure on the right ventricle as it's all pushed in can give the effect of somebody almost being strangulated with an asphyxia appearance with engorged blood vessels of the eyes and head and face. So radiologically, evidence of fracture around the ring or more than 2 fractures or bilateral rib fractures will give you an indication of severity. And the important things to remember is that you're going to bruise your lungs and bruise your heart. So simple monitoring would be ECG and saturations. But the anatomy of the rib will give you an indication of degree of injury as well, because it's always more than you can see, and usually at the back, because it's between the angle and the neck. And the rib compresses, fractures, and returns. But in doing so, you've probably seen when you're eating spare ribs, when you go out and night out, that it does crack and break, and they form rather sharp points. They can slide in and slide out. And they usually go posteriorly into the posterior mediastinum. So I've seen spikes going into the aorta, and I've seen spikes going into the esophagus as well, and spikes going into the lung, causing severe air leak and severe bleeding. And that's where the chest drain is important, because putting the chest drain in will tell you immediately how much air is coming out and how much blood's coming out. And why a compressed injury of the chest could bleed so much is because the intercostal bundle that runs in the groove underneath. And with that comes nerves. And not infrequently, rib fractures are very, very painful, and pain relief is important. So specifically for the heart, a bruise or thump can cause contusion, suddenly expel all the blood from the right ventricle, give you that asphyxia appearance. Indeed, a rupture would be a death at the scene. But one thing to remember from the heart and major vessel point of view is that the arch of the aorta, although drawn like this, actually runs anteriorly to posteriorly, with the anterior part and the posterior part fixed. Former by the pericardium and posterior to the ribs at the back. So it means that this arch, the sausage shape or big vessel full of blood, is quite heavy and actually swings forward and swings back. And in doing so, there's a potential for tear and contusion at both these areas at that line as it swings forward and swings back. It's also possible to burst a valve. So contusion can cause ECG problems, and beware of those, and arrhythmias, because it's effectively a bruise to the heart, but may rupture a valve as well, and an echo would be important. The lung, like every other tissue in the body, is susceptible, and more susceptible, to bruising. And you can appreciate with your nice aerated alveoli, the thin wall, if you suddenly fill those with blood and bruising or lacerate, your ability to breathe is going to be compromised with hemoptysis, hemothorax, and sometimes profound air leak. Chest drains save lives. The treatment, apart from A, B, C, D, E, if you by yourself and you've got somebody coming into A&E with this trauma, call for help. You'll need a surgeon, you'll need an anesthetist. These people will need oxygen. Chest drains safely, fourth intercostal space, mid-axillary line, both sides, bang, in. You can measure air leak and blood loss. IV access, cross-match, and catheter to actually measure and have some idea of fluid monitoring. Look and count respiratory rate, measure the blood pressure, measure the saturations, and watch the ECG. Many people have concomitant injuries and therefore look for those as well. The most common thing is the sternal fracture, the seat belt or the steering wheel hitting the sternum. And to break the sternum is very painful. People will require pain relief, and they'll require chest support to help them cough, breathe, and expectorate. But because of compression, and you don't know how much compression happened at the time of impact, you need to monitor the ECG, you monitor the respiratory rate, you monitor the saturations, and obviously monitor the temperature because of late infection problems. And failure to breathe, build up of secretions in the chest, and then you have the pneumonia. And physiotherapy and pain relief are going to be important. And most sternal fractures do not need surgery to fix. Most of them, if they're not bounced back and they're not displaced, they will heal in time. But they're very, very painful and can take up to 11 weeks to heal. And that is why your treatment of somebody with a blunt chest trauma, you've got them through and monitored them and all the other injuries, post-injury psychological support is important, physiotherapy to help breathe and move, and pain relief is important because an osteochondritis can develop in the broken costochondral junctions some weeks afterwards and cause severe pain. But beware of fever, powdered sputum, shortness of breath, because this could be infective complications because of collapsed lung, bruising of the lung, and that might need further physiotherapy and treatment. And that's it essentially. Unfortunately, with blunt chest trauma, many people actually die at the scene. And it's those people who get to hospital that should be salvageable, but usually die because we haven't attended to the basics of A, B, C, D, E. Thank you very much.
Thank you, David. That was very clear, straightforward, and very simple for someone like me to understand. So thank you very much for taking us through that. Now we have a few minutes to answer some questions. Quite a few have come in, and I've tried to write down on some paper here some concluding thoughts and to try and pull in a couple of these questions. One of the questions about giving oxygen, I mean, I would ask the question, why wouldn't you want to give somebody oxygen in a trauma scenario? So often if somebody's a polytrauma, they may already come to you in a state of unconsciousness with an airway in place. So they will be getting oxygen. And certainly if there's a big chest injury, supplemental oxygenation is vitally important. You can probably kill somebody quicker with hypoxia than your concern, which is obviously hypercapnia from if they've got COPD.
Yes.
Give them oxygen to start with, deal with what's in front of you. Now, one of the questions,
And indeed, if you've got any hesitation about the airway or capacity to breathe, anesthesia and intubation, one relieves pain and gives you control of the breathing as well. And that's why an anesthetist present is vitally important.
Yeah, brilliant. Okay, quite a few more questions are suddenly coming in. So if you bear with me, I'm just going to quickly read through this. And I hope most of you are anonymous, which is great. So I'm going to say to the anonymous attendees, let me answer your questions all together, if that makes sense. For me, part of the take-home message of someone who is also involved in managing polytrauma patients, but often sees them 24 to 48 hours later when someone goes, oh, what are you doing with the guy with the transected aorta on the HDU bed? And we go, which guy with that transected aorta? If you don't pay attention to that mechanism of injury, so if they survive their injury, they have perhaps blunt chest trauma from a steering wheel. If you don't think about the mechanism, ask questions. What was the speed? What was the deceleration? What did they hit? Did the airbag go off, et cetera, et cetera? If you don't think about the mechanism of injury, you won't go on to think of the potentially lethal problems. And you must always have a very high index of suspicion. I'm a vascular surgeon. I only really think about the aorta in the chest. So I specifically look for that. And look at the clues. If you've got proximal rib fracture, high rib fractures, that indicates a lot of velocity has taken place, a lot of force. And therefore, with the fixed parts in the body that Mr. O'Regan's mentioned, you know that that aorta is going to get stretched and damaged. There was a question about what kind of tests. Again, this is all dependent on how that person presents to you. So this wasn't really a talk on what tests you should be doing, but a pan-CT scan these days for the polytrauma patient is going to take place pretty much as long as they are not in extremis, and that will give you a lot of answers.
That is the caveat. Before you put a patient in a CT scan, they've got to be stable. They're usually intubated, with bilateral chest drains in, your bloods are gone off, they've got IV access, cross-match, catheter in, and you stabilize them. They're safe to be in a CT scan for a moment.
Yeah, absolutely, absolutely.
And you don't go to the CT scan until then. Correct. But as Barney says, the high index of suspicion of what can be damaged and the mechanisms is important.
And so just following on from that, then if you want to think what injury could there be, you just have to think what organs are there and what could it be a disruption of. It's either going to be a disruption of air, of blood, or of gut content. And some of those will be immediate and some of those may be later. So if you're thinking of air, that's easy, isn't it? Your airways, your blood would also include your heart and your esophagus, your stomach, or anything else that might have come up. So some people have been asking about acronyms, atomic or atom FC, and how do we understand all of these things? There's actually 12 things to think about, 6 of which could be lethal on the spot and you die. If you survive that initial hit and you come in, they are the ones that will kill you quickly. There are 6 that are potentially hidden. And I think you could call those all together the deadly dirty dozen if you really wanted to. But in brief, the 6 lethal ones are going to be your airway obstruction, your tension pneumothorax, your cardiac tamponade, your open pneumothorax, your massive hemothorax, and your flail chest.
Yes.
Then there are 6 hidden ones. And someone was asking about tracheobronchial injuries. Think about thoracic aortic dissection or disruption. Think about tracheobronchial disruption, myocardial contusion, traumatic diaphragmatic tears, esophageal tears, and pulmonary contusion. 12 things there that if they don't get you straight away, get you very quickly shortly afterwards if you don't pay attention to them, or a little bit further down the line, perhaps even 24 hours later. The last thing for me that was a take-home message is this is a multidisciplinary process. Trauma, you're never one person on your own, so you must employ the senior help around you. There is somebody who is a cardiac surgeon who can come advise, who can open a chest if need be, who has the skills to do that. Okay. So let me just have a quick look. David, do you want to say anything? Just I'll scan through these questions.
No, and I think many trauma centers, having secured the airway and putting lines in, wouldn't hesitate putting chest drains in before going to CT scan. But if you put a chest drain in properly, I remember seeing a trauma patient, and I was putting it properly. It is basically you've opened up, you put your finger in and sweep your finger around to make sure there's nothing else there. My finger actually was feeling the stomach and the small bowel because the diaphragm had ruptured. And to be honest, with hemothorax is full of blood, on chest x-ray, you might not pick that up. You would on CT scan, but my finger picked it up before even that happened as I put the chest drain in.
Okay, right. Just whilst you're on chest drain, there's a couple of questions. Let me read them out and see if we can come up with an answer. Is there a new way of managing tension pneumothorax? Is inserting a needle into the triangle of safety instead of the second intercostal space, mid-clavicular line advised? Another question is a simple pneumothorax needing a chest drain if the patient is stable. Again, you know, trauma is an evolving art. It's an evolving sport. They might turn up with what you think is a simple pneumothorax. Their GCS may depress, you may ventilate them, and suddenly you find you've got a tension pneumothorax on your hand. So it might be a simple pneumothorax at that moment in time that doesn't need a chest drain immediately, but you must keep your eye on the ball, a regular review. Another couple of questions.
Because that's mechanism of injury again.
Absolutely.
And if you get a pneumothorax with trauma, that's a long laceration.
Yes.
So that's a continual leak.
How would we fix the fractures after a flail chest? That's much more of a specialist question, you know, that I think is slightly off topic. That's down the line. But I think
in the first instance, ventilating a patient, one is pain relief, but two ensures that the chest is expanded. Multiple rib fractures, when a flail, nowadays thoracic surgeons will be looking at fixing them. But that's not what's going to kill the patient immediately. It's the concomitant injuries.
Yeah, okay. Let me see. What if you're at home and paramedics, it's just moved off. Paramedics are far away and you don't have a medical kit. What is the most appropriate procedure to do in a patient with a flail chest and a pneumothorax? I think probably start praying. Mr. O'Regan, would you like to add something to that question? It's a very sexy thing to open somebody's chest.
A flail chest, because it's coming in and out with your breathing, is going to reduce your tidal volume. So albeit difficult, to put a soft pad against that, bind it to stop the paradoxical movement. That will reduce the pain as well. But the important thing is, while you wait for help, is maintain the airway.
Good. Brilliant. There's a question on penetrating trauma. I'm going to bounce that to another talk because this is specifically related to blunt trauma. There is a previous webinar that you can go to the archives on chest drains, and that will also answer the question on the safe areas for inserting your chest drain. So
there's only one safe area. That is the mid-axillary line, fourth intercostal space, which is usually just above the line of the nipple.
And what if that area's been traumatized, David? What would you do if that was involved in the injury and they still had a pneumothorax that required a chest drain on that side?
Well, if the chest was intact, you can still put in, with blunt dissection, a chest drain. Yeah. You're not going in with sharp material. You're breaking the skin, splitting the muscles. Yeah. That indeed might be the case, but it's still possible to put a chest drain in, yes.
And you've got to remember, these are often very severe cases. So you're not trying to do something cosmetic or something, you know, gently. You're trying to save somebody's life. So if they are really that badly traumatized, you've just got to make it work. And unfortunately, with senior support, then you could do that. How soon could you develop post-traumatic infective complications? I suppose that really depends on what part of your body's been injured. If your gut has been disrupted and that's not noticed, you may become septic quicker than somebody who has just a simple hemothorax. But of course, the answer to that question is very difficult to answer because I don't know when they would get their infection. You just need to keep your eyes open and your regular review and do all your usual doctoring that you would do.
A bit like any post-op patient, actually, failure to breathe without controlling your pain relief afterwards, we know that basal-active comes on in 3 to 4 days.
Yeah.
That's the reason why you get a temperature. But by the end of the week, that leads to consolidation.
Yeah. Okay.
So as Barney said, depends if another viscera has actually been pierced. And if it's gut contents or esophagus, then fairly quickly, I'd say.
Yeah, brilliant. Well, listen, we've come to the end of our time. I mean, that has flown by. It's 4:30 already. I'd like to thank you all for your attention. Thank you. Sorry if I didn't get to answer your questions, but thank you all for asking them. Thank you for paying attention. Mr. O'Regan, thank you ever so much for lecturing us on blunt chest trauma. Coming up on your screen now is the header for the next series, which is on Thursday on managing the lower GI bleed. So please do tune into that. That will serve to be quite an